we have our gloves, we have 1 milliliter of EDTA treated blood, we have our 15 milliliter vacutainer, got a syringe to draw up our blood, we have the 9 milliliters of a 10% formalin, have our microscope cover slip, and then we have our microscope slides as well as our counter stain. So we are going to take 1 milliliters of blood, put it in our vacutainer, and then add the formalin. And then you want to put our cap back and invert that several times. That way we get it thoroughly mixed up. And then we're going to centrifuge our sample for 5 minutes between 1,000 and 1,500 rotations per minute. Our centrifuge has stopped spinning. We are going to just very carefully remove our vacutainer and make sure not to disturb the whitish pellet at the bottom. We're going to use a long pipette to remove the supernatant from the top. And while we're doing this, just be very careful not to remove or disturb your pellet at the bottom. Okay, now that we've removed most, if not all, of our supernatant, we are going to get just a single drop of our methylene blue. And then we're going to add it to our pellet. And then we are going to just very gently mix that little white pellet with the methylene blue, and then we'll take a drop of that and place it on our glass slide. Place a cover slip over the top. Use our modified knots method for the concentration and identification of microfilaria, specifically to differentiate the heartworm Dirofilaria mitis from the non-pathogenic microfilaria dipet for short. We've got it focused on our 4x. Now we're going to move to the 10x objective. Look for Dirofilaria mitis. And I do not see any Dirofilaria mitis. Simple fecal flotation. We have the microscope slide, the cover slip here that we're going to put on the top of our meniscus here in a minute. We have our fecal cup, our fecusol. We've got about 2 grams of fecal sample. We also have a piece of gauze. So you need about 2 grams of your fecal sample to go ahead and mix up with the fecusol. And then you want to really mix it up. So I've got this tongue depressor. Just try our best to get it off of me. And then we're just going to really mix it up as best as we can. We do the fecal flotation for several reasons, but it's based on a method of the differences in specific gravity. So the flotation solution has a specific gravity that's higher than the specific gravity of intestinal parasites in different life stages. So usually the intestinal parasites have a specific gravity between 1.1 and 1.2 grams per milliliter, and the fecal solution is greater than that. That way we can hopefully see some intestinal parasites that are present in the fecal and strain it. And put our strained material in there and do the same thing, just cause a little lip on the cup, pour it into the fecal cup. We're going to put our second piece in here, stool all over the counter, and then you want to put the fecal solution in your fecal cup until you form a meniscus. We're going to take our cover slip and just gently place that over the meniscus like that. Run our test for 10 to 15 minutes. The fecal float is done setting here. We're going to take the cover slip and put it on our microscope slide. For fecal flotation with centrifugation, we are going to be doing this test today because it gets more ova and cysts in a shorter period of time as opposed to your simple centrifugation or simple flotation. We only need about 2 grams of the fecal sample. Make sure it's as fresh as possible. And then we have our 2 tubes that we're going to be centrifuging. We also have our straining cloth. It's just a piece of gauze, and we're going to be straining this over the cup instead of directly into the tube. That way we can catch more of the sample and put that into the tube. We also have our fecal solution that we're going to be using to help strain the sample, and then we've got our gloves to stay clean and handle our sample properly and safely. The 2 grams of our fresh fecal sample. I've got my stool sample in here, and I've got my fecal sol that we're going to be mixing it up with. And then we'll go ahead and strain the sample. You can use a tongue depressor. Just want to make sure that we strain it really, really well before we put it in the centrifuge. And demonstrate my best here. When I'm doing this, I'm just very lightly pouring this into the cup, and it's just slowly straining through that gauze. Take our container, or vacutainer that we're going to be centrifuging this piece in. And we do want to make sure that our centrifuge is balanced, so I'm going to pour equal amount of the fecal sol up to the, try and get it as close as possible. That way we can make sure that the centrifuge is balanced and it spins properly. Traditionally, you want to use a tabletop centrifuge that can accommodate rotation buckets. That way we can put a cover slip over this, and we would actually fill the fecal solution all the way to the top. For both of these, we would put a cover slip on here. We don't have a tabletop centrifuge, so we're going to use our normal one. We're going to spin this down for 5 minutes. Our centrifuge has stopped spinning. We need to just very carefully remove our tubes and fill the top of the tube and with the fecal salt solution until it forms a meniscus at the very top. We've got a nice meniscus right here. Just let that spread, and then we'll go ahead and start our timer for 10 minutes here. Our sample has the cover slip sitting on the meniscus for 10 to 15 minutes. We're going to place it on our microscope slide, get direct fecal smear. This involves the least amount of material needed. It's one of the simplest fecal tests that is available. The only disadvantages to the direct fecal smear is that it just uses a very small amount of fecal matter. So if we have a low parasite presence, it can be really hard to detect or pick up those parasites on a rapid screen. So it's always best to pair this with other tests as well, but it helps to get a quick diagnosis. So for this procedure, is our fecal salt solution. We have our fresh stool sample. I'm using a cotton tip swab to help collect some of the fecal sample and roll it on the slide. We've got our microscope cover slips, and then of course we have our microscope. So we're going to go ahead and get started. We want to try and use equal amounts of the stool and the fecal salt solution here. This very, very tiny amount here on the end of the collection container is more than enough of what we need. So we're going to put a couple of drops fecal salt solution on our slide, and then we're going to just gently roll our fecal sample from our cotton tip swab on. It's thin enough to actually look through. You should be able to look at like newsprint, just letters, through the slide. If it's too thick, you won't be able to evaluate it microscopically. And then the only other downside to the direct fecal smear is that extraneous fecal debris can be confused with parasitic material. If you've got any large debris on here, go ahead and remove that before you put your cover slip on. Once you've got that thin film, go ahead and place your cover slip on here and then start at your lowest power objective. To do our fecal sedimentation, for this test we have a tongue depressor while we are mixing the fecal sample with the tap water. About 2 grams of that fecal sample, 2 cups gauze, just like before, to strain that solution, and then we have our 2 vacutainers, a fixed angle centrifuge, and so we'll work with that today. We also need a microscope cover slip for the end of our process, and then of course we'll need our microscope slides here. Very small amount of fecal sample, just 2 grams. That you mix it really, really thoroughly. One of the major downsides to this test is that it is very laborious. It takes a lot of time, take a lot of materials. One of the primary parasites and ova that we're looking for in the fecal sedimentation is things like flukeworms. The sedimentation is mainly used for testing with ova parasites that are just too heavy to float. So our fecal flotation would be a good test. Our sample has strained. We can go ahead and pour it into one of our vacuum containers. Now we're ready to centrifuge. And you can see some of that sedimentation there at the very bottom. Pipette off a lot of this supernatant up here until we get to the sedimentation at the bottom. That sediment, I'm going to just put a drop on there. And then we're going to put our cover slip like that. Now we're ready to look at that fecal sedimentation under the microscope.
Okay, so we're going to do our free catch on Murphy. We have some of our supplies here, including a syringe to drop the collected urine. We've got just a clean baby wipe. We've got our ladle to catch the urine, and then I've got some gloves. That way I can stay clean as well. So the first thing that we're going to do is we're going to wipe off the prefuse and try and remove as much of the contaminants as possible before we collect this sample. Catch a urine sample midstream, that way hopefully the contaminants have been partially flushed out. We get as little contaminant as possible. Good boy. Alright, and now we've got plenty of the voided urine sample, so we're going to use our syringe to collect the sample from our collection container. Now we have our urine-free catch sample. Look at the physical characteristics of Murphy's urine. To look at the urine within 30 minutes to an hour after you collect the sample. Look at the clarity of the urine. So you typically want to hold it up to a background with some lettering. And his urine's pretty clear. Waft the urine, it smells pretty normal. It doesn't smell like it has a lot of ammonia or any kind of sweet smell. The color, it is a little bit like a straw urine. This isn't first morning's urine, which would be best. First morning's urine is best because we don't have that kind of diet impact on the urine sample. It's also most concentrated, and it's our best chance of finding formed elements with first morning's urine. Use free catch because it's the easiest, it's the least stressful way to catch a urine sample.
Cystocentesis allows us to collect a sterile sample for culture and sensitivity. It's free of bacteria, cells, and debris from the lower urinary tract. Positioning for cystocentesis is in standing, lateral, or dorsal recumbency. Line stick cystocentesis method is the most dangerous because we don't have any palpation or isolation of the bladder. We don't know if there's sufficient urine in the bladder, and we also have the danger of perforating bowels, causing sepsis or damage to other nearby organs. The palpation isolation method for cystocentesis includes palpating the bladder and immobilizing it to collect your sample. Ultrasound-guided cystocentesis allows us to determine the size and location of the bladder, as well as visualization of the needle into the bladder wall. For patient in dorsal recumbency, Dr. Coffin is going to perform a blind stick. 12 milliliter syringe attached to a 22 gauge 1.5 inch needle. Inserting the needle into the caudal abdomen and directing it dorsocaudally with gentle aspiration of the urine. Change the needle before placing your sterile sample of urine into the collection tube to decrease contamination from debris and cells collected in the needle during insertion. It's a pale yellow, clear, with no abnormal odor. Poly catheters are silicone and self-retaining. They're more flexible and comfortable for the patients and used for indwelling urinary catheters. The polypropylene urinary catheter is more rigid. It's easier to pass for bladder emptying or catheterization. Our urinary catheterization, it's a 12 ml syringe, so the urinary catheter, some sterile lube, a couple of just baby wipes here to clean off the prefuse with. That way we get as little contamination as possible.
side and extrude the penis. And so we're just going to gently clean the tip of the penis a couple of times. Just make sure it's as clean as possible before we try the catheterization. Good boy, Murphy. Good boy. Okay. And then we need to open our sterile lube. I feel like he needs the 5. And then as far as measuring for the placement, you want to do the caudal portion. You want to measure up to the caudal portion of the bladder. So it should be about right in here. So really, we should have quite a bit of excess with this catheter. Yeah, good boy. Good job, buddy. Okay, and then get some lube on the tip of here. Good job, buddy. Good job. And then we're just going to very gently move it through. And then before I reach the bladder, I just want to put our syringe on. Good boy. Take out the first couple of milliliters of our urine just to take out any contaminants we might have obtained. See that our patient's urine is very clear. It's a straw to almost watercolor.
Ear cytology, we've got a couple of items here. We've got our glass slide. We have our cotton tip swabs for each of the ears. We've got a syringe to collect a small amount of the 0.9% sodium chloride. And that's just to moisten our cotton tip swabs. It's better for collection as well as helps minimize any damage to the ears. So we're going to moisten those before we get started. And we do our ear cytology for patients who present with scratching, have any dark debris in their ears, the ears have a bad smell to them. Go ahead and mark our right and left on the frosted side of our slides there. When we get our samples, we're going to get it from the horizontal canal instead of the vertical. Our dog's ears are shaped like an L, so we have to get this horizontal sample. And then you just want to gently roll your ear sample across the slide. Make sure you get your sample evenly. It's important to do both ears because you can have a completely different ear infection in both of them. You need to know what to treat for. Perform the ear cytology when an ear infection is suspected. Every time you do a recheck for ear infection, as well as for non-responsive and recurrent ear infections. And we've got a good sample for both of our ears. Here is ear cytology staining. We've got our 3 different stains: 10 dips, 15 dips, and then 20 dips. You can also leave them in there for 10, 15, and 20 seconds. And you want to make sure that your sample is completely submerged. Use just sterile water. Just gently wash it off. And just gently dry off the other side of the slide that we're not using. So we're going to start off with the lowest setting, which is our 4 objective, and then move to a higher power at 10 objective. And then we are going to use some immersion oil. And right now, all that I see is some big clumps of skin cells. I don't see any bacteria or yeast. So I'm going to move to my 10 objective. Use some of my immersion oil on here. You really just need 1 or 2 drops. I'm seeing some waxy debris and wax in the ear in small quantities is normal. Normal cytology. Present themselves with alopecia, hyperpigmentation, chitin acne, pustules, things like that that would indicate the need for a fungal culture. Bought our gloves to modify test medium, have our sterilized hemostats. Toothbrush method is used if our patient presents without lesions, non-classic lesions. Pluck about 10 to 20 hairs from the periphery of new or expanding lesions. You could also use a Woods lamp to see if the dermatophyte will fluoresce under it. There's about a 50% chance of them fluorescing. Okay, so we've got our hair sample here, and now we're going to put it in our media, and we're just going to very gently press it into the media, but we're not going to bury them. To properly label your samples with the patient's name and then the date of inoculation, that way it doesn't get confused with any of the other patients who we might be doing at that same time. We have our lactophenol aniline blue. We have our culture that's been incubating for 21 days now. We have just clear cellophane tape, and we've got our hemostats because we'll need to do an impression at the colony site of incubation. And then the first thing we're going to do is just put a very thin line of the phenyline blue on here. I'm going to open our culture, and you can see we don't have any medium color change. It doesn't appear that any colonies have formed. But we're going to look at this under the microscope to be sure. So we're going to take the sticky side and just very gently press it against our media. And that's going to be at the site of inoculation. And so now that we have our sample, we're just going to be very careful. Cut it down the middle top section. And that way the tape will be acting as our microscope cover slip. Place our tape just right on top of the lactophenol blue that we have. And then we're going to look at it under the microscope under the 40 objective. and look for spores. But I am not seeing any spores, so it looks like our patient does not have any signs of dermatophyte. For skin scraping, we have our scalpel handle, our scalpel blade, some gloves, 40 blade electric clippers. We have our microscope cover slip, microscope slides, and then we have our mineral oil. We do a skin scrape if we're suspecting ectoparasites. You want to choose your site of skin scraping based off of the freshest lesion where we might suspect that the ectoparasite is. And then as far as the depth of how you should scrape, depends on what kind of ectoparasite we suspect we have. So for Sarcoptes, they're burrowing mites, so we would want to scrape until we get a little bit of fresh blood. We're going to perform a very shallow skin scraping for parasites that we suspect are just kind of on the top of the skin. We just want to save a small area of hair. We're going to be doing a skin scraping like that. And then we're going to arm our scalpel handle. Before we start scraping, we're going to put a drop or two of the mineral oil on our slide. And then we're also going to put some on our blade. And then we're going to hold our blade just perpendicular to the skin. We're doing a very superficial skin scrape. And then we want to just brush it in the direction that the hair is growing. And then we'll get our skin cells. Going to just place our sample on the slide here and then go ahead and do a second scrape. We've got our sample, so we'll go ahead and place our cover slip on there and then look at it under the microscope. Look at our skin scrape. Now that we've obtained our sample, we're going to be using just the 4X objective. I'm seeing quite a bit of debris and epithelial cells, but no surface dwelling ectoparasites. Necropsy is a thorough examination of the external and the internal organs of an animal's body, as well as to determine the disease process or processes that led to an animal's death. We can also use a necropsy to determine the effects of treatment on the animal's body. You really want to perform the necropsy in an area that's not usually used for surgery or treatment. You want to be able to move around your patient during the necropsy easily, as well as be able to clean the area, disinfect it, and then dispose of any items necessary during the necropsy. Personal protective equipment for a necropsy involves many items. You can use an apron, you can use a lab coat. We choose to use a removable long-sleeved smock. That way we can take it off when we're done with the necropsy, disinfect it, clean it, or destroy it if we need to. We have our protective eyewear. That helps to avoid any contamination and protect our eyes from any bodily fluids. We've got our gloves here, which will protect us against any formalin splashback that we have when we're using it. Formalin is a known carcinogenic, and it also has, it's very irritating to the skin. We also want to use this to protect our skin if we have any cuts, things like that, from getting any transmissible diseases. We want to wear our mask to help protect from any aerosolized infectious diseases as well. And then we've got booties. This is usually used more in large animal necropsies to protect your shoes from contamination. The instruments include a variety of different tools, such as our necropsy knives. You want to make sure that they're very sturdy, they can be sharpened, they're not going to break easily. We also use nail trimmers instead of pruning shears. This helps to break through the ribs when we're opening the rib cage up, as well as to cut through other bones. For our tissue biopsy samples, we're going to be collecting with the Adson tissue forceps. They hold delicate tissues, don't pierce or tear through them. And then to hold our tissue back, such as when we're opening up the abdominal or thoracic cavity, we're going to be using our rat tooth forceps. It's important to use a scalpel handle with your blade when you're opening up the abdomen. That way you stay safe. And then we're also going to be using our Mayo scissors to continue to cut through thicker tissue that would be hard with our blade and scalpel handle. We also have our biopsy jars here that contain formalin. We also want to make sure that with our samples we include the history in that, so if the patient died of unknown causes, what our findings are during the necropsy, vaccination history.
We'll be performing a necropsy on this dog, and I am Jessica, and this is Dr. Anna Coffin.
Hi. So first off, we're going to do our external exam on the animal and list any abnormalities. So the main thing that you want to be looking for would be any external bruising on the skin. So you can look at the conjunctiva, look on the lips to see if you see anything, any blood in the mouth, any blood coming out the nose, any bruising. This dog does have a small laceration on its abdomen here. Also has ticks. You want to notate any type of parasite seen. So that's pretty much it on this dog. It is an unneutered male. And then what we're going to do is go ahead and open up for necropsy. And we just do a midline incision. Notate if there's any blood in the in any of the orifices. So nothing visible blood-wise in the thorax. There's no fluid, excessive fluid in the abdomen. Now this is abnormal on this dog. These little white dots. We'll take some samples of that, but no fluid or blood in either cavity that we see. You also want to take a good look at all of the lung fields, see if there's any nodules. Some of these changes that we're seeing in the lungs are just from the dog, the euthanasia, and the dog, being on its side and whatnot. So the other thing, if you're interested in looking in the heart, you can actually remove the heart. I don't need to do that on this particular dog, but you can open that up and look. Sometimes we'll see heartworms in there. If they have heart disease, you definitely want to do that. We're just going to take a few samples. The liver looks normal. The spleen looks fine, but basically you go through the entire contents of the abdomen. This dog does have a great big bladder. Look at the spleen, make sure there's no masses on it. If there's anything that looks abnormal in color, consistency, you want to definitely take samples of that. So what we would do is, this is the spleen. So let's say there's a nodule here, then we would take a sample of that, and then we would put it in there for histopath. But I would definitely recommend you get a full thickness. Hand me a 4x4. And then you take take that, and obviously each one of these samples has to be in a different container. We'll take a section of the spleen, and you know, if the lesion is all throughout the organ, you can just take any little piece you want. If it's some type of a mass, then you need to obviously take the section where the mass is and get that sample. And again, for cultures, you can't use formaldehyde, that's not going to work.
We perform vaginal cytologies to determine when an intact female is nearing or in the estrus cycle. When we perform the vaginal cytology, it helps us determine which cycle of estrus she is in. The first cycle of estrus is anestrus. It lasts less than 4.5 months. At this stage, we don't see any clinical signs of vulvular swelling. She's not attracting any males. We don't have any discharge. Microscopically, we'll see predominantly non-cornified squamous epithelial cells. We'll see some neutrophils and then no erythrocytes. Proestrus is the second stage. At this time, it lasts for about 9 days. We do see vulvular swelling, a little bit of reddish discharge, but she's not receptive to intact males ready to breed. In early proestrus, we'll see a high number of erythrocytes as well as basal and parabasal epithelial cells. The number of epithelial cells start to show signs of cornification, and then the number of erythrocytes starts to decline in late proestrus. Estrus is the third cycle. At this time, we'll see swollen vulva, a reddish discharge, and she is receptive to males. This stage lasts an average of 9 days. We'll see that the squamous epithelial cells are cornified and anuclear. First, we won't see any neutrophils microscopically, and then there will be a rapid increase in neutrophils as well as a decrease in erythrocytes. Mid-estrus is the fourth and final stage of estrus. It lasts about 2 to 3 months. At this time, clinically, she won't be attracting any males. She won't be receptive to breeding. There will be a decrease in the vulvular discharge as well as swelling. Microscopically, we'll see an abundance of cytologic debris as well as non-cornified epithelial cells. Sterile gauze, we have our gloves, our sterile cotton tip swab, our microscope cover slip, our glass microscope, and then we have a couple of our sterile sodium chloride syringes that we're going to be using to clean the vulva before we do our cytology. So we're going to put on our gloves first, and make sure not to let the tail drop after you clean the vulva, because then it'll contaminate your sample. Put some of our sterile saline on our sterile gauze, and then use that to wet the vulva. Before I get my hands dirty doing that, I'm going to just very lightly saturate with some saline. Okay, and we'll set that aside. Okay. So with our vulva, what you want to do is just clean the outside and then try and clean a little bit of the inside as well. And this is in preparation of cytology collection, sample collection. Okay. So now that our patient's prepared, we are going to insert our cotton tip swab almost vertically, and then we're going to move horizontally, and then just very gently move it forward a little bit. And then just very gently, we want to roll sample So we've got our sample here. And then we're going to just very gently roll our vaginal sample here, that, and then put a cover slip on it and look at it under the microscope. Do our cytology stain for the vaginal sample that we got, and then we're going to do 10 dips, 15 dips, and 20 dips. Very gently blot. Okay, and then we're going to look at our cytology under the microscope. So we're going to start at our 4 objective and focus in on our sample. Move to our 10x. Our 40x. Open our condenser to let more light through.
What you doing, Pee-Pee?
And then apply a drop of our immersion oil. And so our patient today, it was pregnant. We did spay her. Non-quantified squamous epithelial cells. We're seeing quite a few neutrophils in here. Seeing quite a bit of cytologic debris as well. And then I'm also seeing some intermediate cells, but no erythrocytes. So we do believe that she's in the mid-estrus cycle.
Cross-matching agglutination test is used for determining blood typing for dogs and cats who are considered for a blood transfusion. So we got our lavender top 2 blood labeled with our recipient Emerald, and then we have our serum separator tube as well. And it's really important to make sure that you properly label your tubes. So our donor dog is going to be Xenia, and we have a lavender top and then a serum separator tube. So we're going to centrifuge all of these tubes. Our sample has finished centrifuging in the EDTA tube. We're going to decant the plasma until we reach the erythrocytes left in the tube. Use a clean new pipette to transfer 2 drops of the erythrocytes from the EDTA tube to our new 15 milliliter vacuette container. Then fill the vacuette container with 9 milliliters of saline. Gently mix the new solution by inverting the capped vacuette several times. Now repeat the erythrocyte washing procedure with the donor's blood sample in the ADATI tube. Centrifuge our new mixtures for 1 minute at 3,400 rotations per minute, decanting with supernatant each time, We're going to repeat the erythrocyte washing 2 additional times. The samples in the serum separator tubes have finished centrifuging. We're going to remove the caps from the serum separator tubes and then transfer the serum to plain rim top tubes. The final erythrocyte wash is finished, so we're going to remove the supernatant, which should be clear and colorless. This indicates that the erythrocytes are thoroughly washed. Place 0.02 milliliters of packed washed erythrocytes in a new label test tube. Add 0.98 milliliters of saline to the same test tube. Then gently invert your new suspension until it's thoroughly mixed. Set aside and repeat the erythrocyte suspension process. Be sure to properly label all of your test tubes. Repeat the 2% erythrocyte suspension procedure with the donor and recipient's washed erythrocytes. Add 2 drops of the donor's cell suspension in the major crossmatch tube. Remove 2 drops of the recipient's serum and place it in a new vacuette labeled major crossmatch. Then mix it gently by inverting the tube. Add 2 drops of the recipient's erythrocyte suspension to the minor crossmatch tube. In a new tube labeled minor crossmatch, remove 2 drops of the donor's serum. Mix it gently by inverting the tube. Mix 2 drops of the donor's serum with 2 drops of the donor's erythrocyte suspension in the test tube called donor control. To check for auto-agglutination, we are going to set up 2 controls. Mix 2 drops of the recipient's erythrocyte suspension with 2 drops of the recipient's serum. in the test tube labeled recipient control.
Invert all of our new tubes and place them in a rack.
Let them incubate for 30 minutes at room temperature.
It's time to centrifuge all of our tubes for 1 minute at 3,400 rotations per minute. Evaluate each of our tubes individually. We're going to examine the supernatant in each of our tubes for hemolysis, which is macroscopic agglutination. So we're just going to very gently tap on our tube here. I don't see any visible agglutination. We definitely should not have any agglutination in our control tubes. Starting with our recipient control, major cross match, donor control, and then our minor cross match. Add 1 to 2 drops of the supernatant from each of our tubes to their respective slides. Place a microscope cover slip over each of the slides for microscopic evaluation. I do not see any agglutination on our recipient control, so we'll move to our major cross match. Start at our 4 objective. Okay, looks like we have no agglutination for our major cross match. We're going to look at our final slide with the minor cross match. And I don't see any agglutination on here. The agglutination would look like a cluster of grapes, not to be confused with rouleau, which is like stacked coins.
no agglutination on here. So it looks like our recipient and our donor, or it looks like our recipient is safe to receive a blood transfusion from our donor.